Am I audible?
Yeah, you're audible,
Yes.
but there's a lot of echo. You may have two devices on.
Okay. Still the echo is quite a lot.
So I don't understand, right?
इसकी डिसेबल करायचं म्हणजे मला यहाँ पे खोले पछि मात्रै So, good afternoon, everyone. On behalf of GoRed for Women, AHA and PCS Pakistan, and the Scientific Council of Women with Heart Diseases, I welcome you all today webinar, which is on the cardiac surgery in women.
Thank you.
This is regarding a tribute to Nena Brownwald. This webinar is a collaborative platform where renowned experts of the cardiac surgery and cardiology will share their knowledge on gender-specific challenges, surgical advancement, and recovery process in women, especially, and gender disparities. Together, we hope to bridge gaps and improve cardiac care for the woman. Now, I will start from the Dr. Ahmad Shahbaz, who will give his presentation on a tribute to Dr. Nena Brownwald. Dr. Ahmad Shahbaz.
Thank you very much, madam. Mr. Zahir, to start my presentation. The webinar on cardiac surgery in women, and we are today paying tribute to Dr. Nena Brownwald, and it's organized by GoRed for Women, Pakistan Cardiac Society, and Scientific Council of Women with Heart Disease. I am Dr. Ahmad Shahbaz, Head of Cardiac Surgery Department, Punjab Institute of Cardiology, Lahore. Brownwald was the first woman who performed open heart surgery. First lady certified by American Board of Thoracic Surgery and the first to be elected to the American Association of Thoracic Surgery. At the age of 32, she led the operative team at the United States National Institute of Health and implanted the first successful artificial mitral valve, and she designed and fabricated it herself. She was born on March 1928, and at the age of 14 she became the member of American Society of Immature Microscopers. She received her medical degree from New York University. From 1952 to 1955, she was trained in general surgery at New York Hospital. She also worked with Dr. Charles, who was the inventor of first artificial heart valve. She worked under the mentorship of Dr. Andrew. In 1958, she was a staff surgeon at National Heart Institute and the deputy chief of clinical surgery till 1968. In 1960, she performed first successful human mitral valve implant in a 44-year-old lady with mitral regurgitation. She developed a cloth-covered mechanical valve which was implanted into thousands of the patients during the late 1960s and early 1970s. She also contributed towards the development of stented aortic homograft. She received many awards in 1960s and 1962, and including the Golden Plate Award of the American Academy of Achievement. She worked as Associate Professor, University of California, Howard Medical School, and staff surgeon at Boston Children's Hospital, along with her other important positions. She published more than 110 articles in different international journals, including Circulation and the New England Journal of Medicine and Journal of Thoracic and Cardiovascular Surgery. Following her death, the Thoracic Surgery Foundation established Nena Star Brownwald Research Grant. This foundation also offered Nena Star Research Fellowship, and the Association of Women Surgeons is also providing Nena Star Brownwald Award. She was married to Eugene Brownwald, a renowned cardiologist, and she had 3 daughters. Dr. Nena died of cancer in 1992 at the age of 64. To know her better, we must listen to her colleagues in the following video clips. These video clips will give motivation to our emerging female cardiac surgeons. And thank you very much from my side, and I must appreciate the efforts of Dr. Khalida Soomro for taking such a promising initiative. Thank you very much.
Thank you, sir.
Howard, let me introduce today's distinguished chairpersons. Dr. Hasna Sharif, Professor of Cardiology, Cardiothoracic Surgery, Aga Khan University of Health Hospital, Karachi. Professor Asad Awan, Professor of Cardiology, National Institute of Cardiovascular Diseases. Dr. Ghazala Irfan, Associate Professor and Electrophysiologist, National Institute of Vascular Diseases, and she is the head of the Department of Electrophysiology as well. Dr. Rifat Tanveer, Associate Professor of Cardiac Surgery, Dow University of Health and Sciences. I will request Dr. Professor Hasna Sharif and Dr. Rajkumar Sajdivani. He is the President of Pakistan. Thank you, Dr. Rajkumar, for joining us. So now I will request Professor Sharif to give his comments on the prevalence of such cardiac diseases in Pakistan where surgery is required. What is the gender difference in between these procedures?
Yes, Bismillah ar-Rahman Assalamu alaikum, and thank you very much, Dr. Khalida. Can I just add to about I was lucky enough to be in Boston in the centers where Nena Brownwald trained, and my mentor was from University of California, San Diego. So I have kind of seen the Brownwald. To your question, definitely some reason. The issues are perhaps than so they come for surgery because they may have arrived late. The outcomes are not good, and that's been shown in study after study, not just in the Western world, but more in LMICs. So I think the exact causes are probably unknown, but I think this neglect women, they neglect themselves. They're probably neglected by the households as well. And I think late presentation is probably one of the reasons. Second could be the BMI issue. Talk about it. The BMI could be low in women or perhaps even high. So both extremes of the Gaussian curve for BMI is probably also responsible for relatively poorer outcomes. But we'll wait and see what our experts have to say today, and I'll reserve my comments for the end. Thank you.
Our next chairperson is Dr. Vadala Irfan. She is head of the Department of NICVD, Electrophysiology Department, first becoming performing a lot of procedure, electrophysiological procedure, and he is the chairperson of our fellow. So we can judge that why I have asked her to help us in cases of heart failure, and how she will be helping the women of Pakistan and Sindh. And what is the ratio of performing primary pacemakers and their devices in her department? What is the gender difference in between men and women?
Good afternoon. Thank you, Dr. Khalida, for inviting me. As far as the gender difference is concerned, as already Dr. Hasnat has already said that I think it's all over the world that females usually downplay their symptoms. So they come late to the came late to the hospital, and even if they come to the hospital with a lot of cultural issues, getting a procedure done, and even after, and they have to think if they're getting the procedure done, who is going to take care of them. So these all things actually increase the morbidity and mortality in female patients. And same applies to the patient with a heart failure and even with electrophysiological procedures also. And we always see the same issues here also in our clinic, that once a female patient comes for a procedure, she has to think whether there is vacations for the children or not, who is going home to the children if she's getting admitted for a procedure, and these things increases the morbidity and mortality. And it's not a huge difference with I'm going to say between male and female patients per se, but getting the treatment is for a female patient, it takes a long time for a female patient to decide for any procedure as compared to a male patient, because for a male patient there is a lot of support at home to take care of the home things. But once a female is a patient, she needs to think who is going to support the household if she's coming to the hospital. That is something which I have seen over the period of time. We have recently done a study also in which we try to find what is the gender difference in patients who are presenting to us with supraventricular tachycardia and how long they are getting the treatment. So you can imagine, as compared to male and a female patient took at least 8 years to seek treatment, and after seeking the treatment, first hospitalization visit, then getting the treatment done. So it's almost 8 years difference. So I think the same goes for the surgery and the rest of the procedures also. I would like to see the rest of the presentations also, and in between, I'm available actually by 3:30 because I have a clinic. So that's why Dr. Khalida gave me the opportunity to give the comments earlier. Thank you very much, Dr. Khalida.
Dr. Rajkumar, are you there? So let us start with our presentation. Our first speaker is Dr. Radha Bhattari, consultant cardiothoracic surgeon from the Parpur Hospital Research Center, Nepal. Cardiac in women, unique challenges and consideration in women. Radha, are you prepared to deliver your talk? Radha?
No.
Yes, ma'am.
Yes. Hello, it's good.
Good afternoon, respected organizer committee. Thank you, Dr. Khalida Soomro, for giving me this opportunity. Can I see my presentation?
Oh.
My topic is cardiac surgery in women, unique challenges and consideration. Next, please. I have no disclosure. Next, please. We will talk about impact of cardiovascular disease, how women are different from men, some of the challenges and opportunities we have for treating women with this disease. Next. Next, please. Cardiovascular disease remains the leading women in worldwide. 1 in 3 women dies from cardiovascular disease, and 45% of women more than 20 years of old have some form of cardiovascular disease. Historically, women have had higher morbidity and mortality after cardiac surgery. Next. Next, please. Next, please. This slide shows the women with this disease. If we look at these graphs, we can see that ischemic heart disease and strokes are the leading cause of death in the world globally. On the left, we can see the number of deaths in millions by year on the bottom from 1990s to 2019, and you can see that the number of deaths due to cardiovascular disease unfortunately have been rising every year. And on the right we can see countries with the highest number of cardiovascular disease details. At the top we can see China and India, then the Russian Federation, and then the United States of America. And we can see in 2019 in the dark blue more deaths than 2010 in the light blue. We also know that the risks and prevalence of this disease continues to be rise. This is a pie chart. Next, please. Next, please. This is a pie chart of cardiovascular disease, includes all these. See, on the biggest portion of the pie chart is in red, which is ischemic coronary heart disease. And I would like to talk about sex bias in research, basic and clinical research. Although women are known to differently exhibit disease-related symptoms, metabolize drugs, and respond to therapies, many new therapies were not historically tested directly on women. Over the past 100 years, the drug discovery pipeline has primarily used male-derived cell lines, male animal models, and male human subjects. As male animals have no ectorus cycles, they have less physiological variability and more predictable behavioral patterns. Thus, scientists have historically favored during male animals in the research. Next. A 2015 Government Accountability of Fish report raised important concerns that National Institute of Health founded studies need to report not only women's enrollment but also differential sex-based treatment effects. Evaluating surgical risk project, our 2016 publication documented that 38% of reported detailed sex findings, 33% analyzed sex-based findings, and 23% discussed sex-based results. Unless a scientifically rigorous single sex-based research study relation exit, research studies should be required to have sex balance design, analyzed, and reporting. Next. Documenting the for 32 aortic aneurysm trials, the PPR was 0.46. In contrast, the 30 heart valve disease trials, PPR was more than 0.8 for all time periods evaluated. Moreover, the PPR increased between the two times periods associated 2003 to 2008 and 2008 to 2017. Outside of valvular heart disease trials, however, enrolling women in cardiac surgery trials remains challenging. Next. From 2011 to 2012, 5 surgical journals papers revised publications were evaluated for potential sex bias for the 78% of animal-based projects where sex was reported. 80% of included males only and 70% included females only, and 3% included both sexes. For in vitro cellular studies, only 24% of publications documented the cell line sex of those reporting sex. 71% included only male cells, and 21% used only female cells, and 7% used both. Next, please. Not just a disease of older women, more than 9,000 women in the US younger than 45 years of age have a heart attack each year, and incidence is 1 in 8 for women aged 45 to 64 years, and death rate in US women 35 to 54 years are increasing, likely because of obesity epidemic. Next, please. And symptoms are different. In female, atypical chest pain, more common in women, abdominal pain, shortness of breath, nausea or dizziness, unexplained fatigue. Women have longer time from symptoms onset to presentation. Do they tend to ignore symptoms? Or women are caregivers for others, and they also give her own health is at last priority. Next. Women average of 18 years older, women are different from men. Multiple risk factors, comorbidities, urgent or emergent presentation, sudden death, silent MI, more likely to die within 1 year following a heart attack. Risk factor, greater disabling symptoms, less likely to undergo cardiac catheterization, shift revascularization. Next, please. Next, please.
Not listen.
Do you need help, Dr. Counseling? Are you having problem with internet, Dr. Radha?
I think she is not with us, I think, at the moment. Mm. She must have dropped.
So, can Dr. Hasna, for a woman with atypical symptoms, what protocol for the diagnostic pathways you recommend for early detection of underlying cardiac disease?
I think our whole threshold has to change. Our threshold has to change from a high threshold to a very low threshold for these women with atypical symptoms. I remember very distinctly when I was in London, they reviewed all their women who had presented to clinics with atypical symptoms, esophagitis symptoms, and most of them were found to have coronary artery disease. So I think the increased awareness in the public, increased awareness with the general physicians, increased awareness in the cardiologists, and quite clearly the patients to present themselves early is the key to early detection, which could possibly lead to early treatment and better outcomes.
Thank you so much. We are now moving towards our next speaker, Dr. Bildana Parapet, but she is currently busy in the ER with a serious case, so she might join later on. Our next speaker is Dr. Farah Sobia.
Yes, ma'am. I'm available. I would like to request you to kindly share my presentation,
Yes.
please. Thank you. Ma'am, can I start?
Farah?
Yes, ma'am. Can I start, please? I hope that I'm audible to everyone.
Yes.
Okay, ma'am. Nice meeting you all, and thank you very much for giving me this opportunity today to talk on heart valve disease in women, the surgical outcome and gender differences. Ma'am, I am a new cardiac surgeon, just started my journey in the field of cardiothoracic surgery at Rawalpindi FIC. And I just want to start my presentation by asking you all, is it true that men are from Mars and women are from Venus? It is a statement taken from a book by Mr. John Gray, basically on psychosocial differences in men and women. Based on this, I would like to go to my next slide, please. Next slide, please. Although there are changes, differences between men and women in psychosocial, but biological differences between men and women are the main reason for different pathophysiology, prevalence, etiology, diagnosis, perception of symptoms, management, surgical outcome, etc. in women as compared to a man. Although in our in our low social factors, they are also very important for the timely presentation of women at a tertiary care or at a nearby facility where they can be assessed and diagnosed at an early stage so that they can have a better management, whether it is surgical or by structural or by conservative. Or also there are behavioral and psychological factors which are all hindering for early presentation of women for treatment, specifically early diagnosis and for management further. Next slide, please. This slide of mine, basically, we already talked about it, that there is underrepresentation of women in all the specifically low-income countries. As a result of that, the women, they usually present at a very, very later or delayed or advanced stage, as a result of that, when they are intervened at a advanced stage, the outcome definitely in women are different as compared to a man. This slide of mine basically it describes the sex-based disparity of aortic valve as well as the mitral valve. I think this is very much already touched by many majority of you before. So I would like to proceed further so that I can touch basically the surgical outcome by my own data. Sir, all of the data presented today is basically from Pakistan, and this is basically the prevalence of the valvular heart disease in women and of the rheumatic heart, which is the commonest in Pakistan. And then the calcific aortic valve disease in women, the prevalence, as well as the degenerative mitral valve, as compared to men, females or a woman is more prone to rheumatic heart disease and specifically at the mitral area. Okay, kindly next, please. And because of the different factors, the severity of the disease, whether it is mild or mild to moderate, or moderate severe or severe, it is basically because of the delay in the presentation of women at a setup where they can be diagnosed rightly. As a result of that, in mitral stenosis, majority 76 to 78% of the women, they are presenting at a severe disease with atrial fibrillation, with diastolic and systolic dysfunction, and they may have thromboembolic phenomena. And as a result of that, the severity of all the disease of valvular heart disease in women is more at presentation as compared to a man. Next, please. This is taken from a recent study in 2024 from NICVD. Basically, it illustrates that if we have a multidisciplinary heart team management for patients, we can reduce the burden of cardiac surgery. And this slide of mine basically show that out of 2003 patients, about 52.8%, which is about 1,058, they were female. And this give us a split of the severity of the valvular disease. And basically the management with multidisciplinary heart team, it will reduce the burden of surgical surgery, as a result of which we can diagnose the patient who need immediate surgery, those who can be managed by structural like PTMC and valvular congenital heart disease like AST closure by device, etc., even TAVR, and they all can be taken, they can be referred at the right department so that they can be treated at the stage of the disease. Similarly, if they are having mild to moderate or mild disease, they can be more managed by conservative treatment. But it is very important at the same time that we should educate our patient as well as the family that the patient is suffering from a valvular heart disease, which is going to in the near future, and she'd need regular follow-up at the cardiac center or cardiac hospitals, so that she can have a follow-up echocardiography and other parameters can be checked, and at the right time, when no other, for example, atrial fibrillation or some thromboembolic phenomena happen in that patient. So regular follow-up we should educate our patient and family as well that regular follow-ups they are very important for the safe management of the woman with valvular heart disease. Ma'am, next slide, please. I just want to put this slide. Basically, the guidelines which are available for us in our practice, whether they are AHA guidelines or European, they never highlight specifically women treatment. As a result of that, I just want to request, or we should work that women, they are biologically different as compared to men, and the treatment of valvular heart disease, our guidelines, they should also include individualized or tailored treatment and guidelines so that we can manage our woman percentage in a better way as compared to a man. because the severity of the disease in a woman may be more as compared to a man, so that the guidelines, they don't cover that aspect of the management specifically for women. So they should be highlighted in our guidelines so that women can be tackled in a better individualized and tailored way with a better outcome as compared to a man. Thank you. Next, please. Then physiologically, pregnancy is one of the most important factor, because all of the females, they are in their reproductive age group. They are supposed to pass through the pregnancies and etc. As a result of that, majority of the females who are suffering from valvular heart disease, they may get their first diagnosis of having a valvular heart disease when they get pregnant in their second or third trimester. Secondly, females, they are more anemic because of their ops and gynae history. So they are more anemic. Their symptoms may not be only because they are anemia. There should be should get at the same time. Secondly, as a result of the pregnancy, the dynamics, they are different in women, specifically in their reproductive age group. During pregnancy, if someone is having a mild disease of mitral valve, that if there is no proper spacing between recurrent pregnancies, then the severity or progress of that disease may be more as compared to a man. So pregnancy is a very important aspect of a woman health. And if the woman is suffering from a valvular heart disease with pregnancy, we should educate our women and as well as family that the proper spacing and proper follow-up should be done, specifically if they are suffering with valvular heart disease. So, ma'am, next, please. So now let's come specifically to the surgical aspects. We know that women have anatomical differences. The heart of a woman secondary to estrogen in the reproductive age group is smaller as compared to men, as a result of which they also have smaller body surface area, or BMIs are below normal, or they may have the other extreme of above normal, and they may be suffering more from diabetes, rheumatic heart disease, for polyarthritis, and as well as hypertension, etc. They may have endocrine problems like hypothyroid, as a result of which comorbids are also there, which are going to affect the surgical outcome of the patient, woman with the valvular heart disease. In anatomical differences, because at the root of the specifically in aortic site, the root may be smaller, as a result of which they may need a root extension surgery, which is going to increase the technicality of the valvular replacement in a woman. Similarly, choice of valve, whether by bioprosthetic or mechanical, is also very important to be discussed in prior to surgery, because it's very important to educate our families in our setup. Specifically, if they are choosing a bioprosthetic valve, then if they are recurrently passing through the pregnancies and everything because of the reproductive age group, and for social pressure to complete the families, so automatically in bioprosthetic valve, they're going to degenerate at a very early time, secondary to the pregnancy dynamics, as a result of which they may need a redo surgery in the coming future, which has its own risk. So we should educate our patient here that if they are, they have two categories of the valve bioprosthetic or mechanical valve, that should be very wisely chosen by the family. And similarly, in the post-operative recovery, morbidity and mortality, I'm going to present today in the next slide what we are having here at AFIC. Ma'am, kindly next. We are conducting a prospective cross-sectional surgery. Next slide, please. Ma'am, we are conducting a prospective cross-sectional study at our setup, which is basically the main objective of the study is to study the morbidity and mortality in women with valvular heart disease, whether they are undergoing repair or replacements. We started this study by including all the patients presented with valvular heart disease from January 2023 to December 2024. It's still statistical, and all the aspects of the study are in pipeline. It has not yet been published anywhere. I just want to present it here because I may get a better idea and better in different aspects which my data may be lacking. So all the elective and emergency surgeries, valvular heart disease surgery, they were included in isolation multiple. They're also included conventional and minimal invasive approaches. They're also included, and we excluded all the valvular heart disease with concomitant CABG and congenital heart disease, heart defect repair, etc. Next slide, please. So in our data, the total number of patient with valvular heart disease, it was 818, which will be more presented in the next slide. So 818, and we excluded 118 patients because they were all CABG plus MVR, AVR, or DVR, or congenital heart defect repairs in them. So out of 818 patients, we have 222 male and 483 patients of females. And this is the graphical presentation. Females have more mitral valve replacements as compared to men, as well as AVR, DVR. Reduced are more common. Majority of them they have biological about 10 or 12-year ballet before they were implanted at some other hospital, and now they are presenting here with another valve disease, or the primary valve may be functioning well, but there is the disease of, for example, mitral is already been replaced, and now they are presenting with the aortic valve disease, and as well as the in situ previous mitral valve dysfunction may be the reason for the redo surgery. Minimal invasive surgery, this is the pre-op workup. Our data include a mean age of 45.7%, 43.1 of our data have normal, like hypertension, diabetes, CVA prior to surgery, chronic renal failure, and PTMC. PTMC, why PTMC? Because we have emergency mitral valve repair surgeries and surgery in 3 of our patients who are undergoing their PTMC, and because of the injuries, they landed up into operation theater for emergency mitral valve replacements. Then NYHA classifications of our patient. Next, please. Next. Okay, this is the echocardiographic EF as well as the TEPSI in our patient. And out of 483 patients, we implanted 87 biological bioprosthetic valves and 396 medical valves. Next, please. Now coming toward the post-operative complications. Valve-related complications, we have valve-related complications 17.59%, valve-related paravalvular leak, thrombosis, endocarditis, patient processes mismatch. Basically, we want to continue our follow-up of these patients in the future so that we can have more data collected on the PPM, endocarditis, thrombosis, and paravalvular leak. The available data is in the peri and immediate post-op period. And in 483 patients, we have paravalvular leak in 7 patients, which caused about 1.45%. And in males, it is about in 2 patients, and majority of them, one was aortic, and major and mitral valve, both were included in this percentage. Arrhythmia is second valve related, basically Brady and Tachy both have. Then repair, if we have repaired regurgitation in a female 2 patient, which is about 13.3%, they have regurgitation, worse regurgitation of the repaired valve, and 1 mitral valve in a male patient. And cardiogenic shock after in the immediate post-op surgery needing high support IABP or ECMO, and they may have an open chest. They may be shifted to ITC with open chest. This is the different that, and ICU stay and the hospital stay. Next slide will have the graphical presentation of the same. Ma'am, next slide, please. This is the graphical presentation of the same valve-related complications in our patients. Next, please. Then journal complications in our patient. Next. For example, if someone have AKI or they already known CRP, then we have dialysis instead. Both facilities available. Some patient specifically redo, they may need 3 patients and females and 1 patient and male. They need a laparotomy in the post-operative embolectomy in patient. All of them, they have redo surgeries and they have femoral cannulation. And secondary to that, they got thrombosis in the 3rd and the 5th post-op day, as a result of which we did a embolectomy in these cases. Coagulopathy needing transfusions of red cell as well as other products. CVA in women 1.24 patients and 6 patients, 2.7 in men. And respiratory total number was 4.2, 20 cases we have. More respiratory problems in the form of prolonged ventilation time, tracheostomies, recurrent effusion, pericardial effusions is the split of these. Similarly, modern sales and mortality on the whole, we have total is 7.5 in women and 4.95 in men. So women number is 483 and 222 is men. Next, please. Next slide, please. This is the graphical presentation of the non-cardiac complications in women and men in our data. Next, please. In conclusion, next. Mortality is more in women as compared to men, and the majority of them, they have advanced stage, as well as those who have age as well as comorbids and multiple disease. They are more prone to have mortality in our setup as compared to those who are introduction unstable. Okay. So I would like to conclude that women are different biologically as well as socially, and multiple external factors, they can affect the presentation, management, and outcome of women with valvular heart disease. Management should be individualized and tailored, and family support on all levels, it matters a lot for the better outcome. And social and cultural factors, they should be tackled appropriately. Rheumatic heart disease in our setup is the most commonest etiology of valvular heart disease, and mitral valve is the most commonly affected with rheumatic heart disease. And women, they're candidate to undergo valve surgery more in our setup as compared to men. And post-operatively, respiratory complications, they are more common, and the major source of morbidities leading to more stay in ITCs and etc. and age, diabetes, hypertension, advanced valvular heart disease with reduced functional capacity and multi-valve disease. They are major factors for more mortality in our setup as compared to men. Thank you very much. Hello. Thank you, ma'am.
For your presentation. Let's discuss some question based on your talk. I would like to, anybody would like to have any question from
Can I ask a few questions, please?
Dr. Sophia?
Yes, sir. Yes, sir.
Yes. Yes, you.
Right. So, Dr. Farasobi, I think that was a great presentation, especially your attempt to figure out the number of cases that we have. It would be nice for you to look at what the international standard is for these outcomes and compare your outcomes to those standards. And also, I think when you look at it, make sure that you have an adequate sample size.
I understand.
You'll need to look at that as well.
So both the groups, they should be equal in that sense.
Well, no, not necessarily. You can do a propensity score analysis on that. That's not an issue. But I think it'd be nice to compare it to a standard rather than have a standalone figure. I think your comments are very well taken about the valve prosthetic and the mechanical valves. One of the other issues that we have in a country like Pakistan is it's okay to have a repeat procedure, maybe in a public funded hospital. But if they come to a private hospital, cost becomes a huge issue
Very right.
in determining what is value
Yes, sir.
place. The other issues are, you talked about the guidelines. The guidelines, you're absolutely right, do not talk about the gender disparities. The bigger problem, however, though, is that, when you apply these guidelines to a country with rheumatic heart disease, these are not meant for rheumatic heart disease. So they're different. And finally, but not the least, is you've quite clearly shown that the mortality is about approximately twice that of men, and
Yes,
that perhaps is not acceptable. There's a lot of work that needs to be done in this regard.
sir.
Thank you.
Thank you very much, sir.
Luckily, we have Dr. Rifat Tanveer again. She has joined us as a chairperson. Dr. Rifat Tanveer, have you any question from
Assalamualaikum, ma'am.
for us?
Assalamualaikum, ma'am. Thank you very much, and thank you to all. I have a comment, not a question. First of all, I want to say something. She
Yes,
said the male and female are coming from a different planet. No, they are from the same planet, but they are different.
yes,
As she also in her presentation. And I think every patient, irrespective of gender, the management should be proceeded with the multidisciplinary approach that includes cardiologist, surgeon, as well as the anesthetist, as well as the intensivist.
very
And we know the social and the psychological issues are very important, especially in over setup, as also the financial issues are a very important
very right.
factor, because a majority of the patients, they came late usually because of this factor. So this is only, I don't want to ask, but I want to share my opinion in this.
Thank you, ma'am.
Thank you.
Thank you.
Can I also add another comment over here, which is, we talk about outcomes and diseases. Look at breast cancer.
Yes,
Cardiovascular takes many lives than breast cancer, but yet breast cancer takes the headlines. So
very
unless
right.
we change this around, this is not going to change, because even amongst women, if you do that survey, they'll think that there's mortality is more in breast cancer, which is quite clearly not the case.
very right, sir.
I have one question for you, Dr. Farah. It is usually clinical studies has found that women with mitral valve regurgitation have a higher mortality rates after the valve replacement compared to men. What strategies would you employ to reduce these risks in your practice, routine practice?
Ma'am, what we used to, if some women are coming with us with mitral regurgitation, so when we assess them specifically for pulmonary hypertension, and also the dimension a good echocardiography, giving us the dynamics of the right and the left side of the heart, and in the post-op, immediate post-op, what we used to do that we used to keep them for a longer time on vent, and we are going to give them sildenafil and milrinone, etc., as well as to adjust their preload and afterload, so that the dynamics right and left side imbalance should be balanced. We may have better outcome after they are extubated. And also we start our patients at our vicinity, that we start pre-op respiratory rehabilitation. We start our patient education at the pre-op stage, so that they are familiar what they are supposed to do in the immediate post-op and later on 8 weeks after the surgery, so that they can have a better respiratory reserve, so that they can have lesser pulmonary or pleural effusions and other morbidity causing respiratory causes, so that they can have a better outcome specifically from respiratory point of view. So we educate our patient from the very beginning that they should start doing incentive spirometry and so that they are familiar and they can have a better inspiratory and expiratory muscles. They know how to do the deep exercises. That may not be a very new thing for them in the immediate post-op period when they are already having other issues with their pain and definitely low moral strength and something like that. So we just start doing this in the pre-op stage so that we can have a better outcome in the post-op period.
Thank you for your excellent and thought-provoking presentation. Now we have another speaker, Dr. Iram Tarim. She is consultant cardiothoracic surgeon at AKUH Hospital. Her topic is sex-specific approaches in coronary artery bypass grafting in women. Dr. Iram, are you ready?
Yes, ma'am. Assalamu alaikum. Thank you very much for introducing me. I am working as an assistant professor, cardiac surgeon at NICVT National Institute of Cardiovascular Disease.
Okay,
And I'm ready, ma'am.
yeah.
Not at AKU. Ma'am, I would like to have my presentation on screen.
Yeah. Karo. Done. आपके एंड पर है?
No, ma'am.
चलिए ठीक है, हम कर रहे हैं. Okay. हाँ. पहले कर लेते हैं, उसकी प्रेजेंटेशन होगी. Meanwhile, any comment from the our speakers or chairpersons?
Can I just add to the comments? I think you, Dr. Farah, you talked about the aortic, but increasingly, if you leave the tricuspid valve alone in these patients, we have a huge problem. So I think even for men and women, that anything that is more than moderate TR needs to be addressed. You need to, on echo, you need to make sure that the findings are appropriate, the annulus is not dilated, and there's no definitely severe TR needs to be tackled, but maybe even moderate TR needs to be tackled.
Yes, sir.
Anything which is more than mild to moderate, mild to minimal should be addressed both preoperatively and maybe checked intraoperatively as well, because there's an increasing cohort of these patients who come in with right heart failure and end up having huge problems.
Very right, sir. Sir, we all of our patient underwent on-table transesophageal echocardiography, and we assessed in the prior to surgery and post-surgery. And we are doing the repair of tricuspid valve as well as replacement in those who need. And we expect these, although these are few people or few patients, but they are still managed at our setup. Thank you, sir.
You could include that in your study.
Sir, I already included TVR plus TV repair. They are already the data is available in that.
Okay.
I may not talked about it or highlighted it.
Sure.
So it is included already.
Thank you.
Thank you, sir.
Thank you, Prof. We are
Thank you,
now
ma'am.
moving to Iram Tarim.
Yeah.
Iram, your
Yes,
present.
Yes, ma'am. Assalamu alaikum to all the participants, and a very good day. My topic of today's discussion is sex-specific approaches in CABG in women. So I'm working as an assistant professor in NICVD, and it's been 4 years. I passed my FCPS in 2020, and since then I have done almost 550 categories, and most of my patients are women around 40 to 45%, because they feel that it's good to, go to a female surgeon maybe. So today I'll be talking a little about my own experience. I'll be sharing some of my experience and some, of course, the general points. Okay, so why do we focus on the women? Number one is, as my all fellow colleagues already discussed, that women is a little different from the men because of the anatomical and the physiological differences. Number two, the woman presents late to the healthcare centers. The basic thing is because she neglects her health. She never prioritizes her health. For her family is the first thing. So this is the thing. And number two, atypical symptoms. Atypical symptoms, like she never gets the typical symptoms of chest pain and shortness of breath. She always explains, she has her own way of explanation of the symptoms that may confuse the clinician and doesn't, you know. So this is why we need to focus on the women, and especially in the women of my society, where we are getting more from the lower to middle socioeconomic class, the center which I'm working in. So this is why we need to focus on the women. Why outcomes are different? Of course, the same thing, that anatomical and physiological differences. Women with a small body mass index, smaller vessel size when we are dealing with the coronaries, and they have hormonal influences. Hormonal influences, like if we are talking about estrogen, we thought that yes, the estrogen is a protective hormone that protects the woman from the coronary artery disease. But now I think the diabetes is taking more influence over the coronary artery and making it more diffuse disease as compared to the estrogen. Because earlier we were getting women in the postmenopausal stage, but now we are getting more younger women in our center or overall. Next, please. What is the role of surgeon? Number one, yeah. Number one is I feel that there should be an effective communication between a surgeon and a woman that comes to the clinic. It's not just the women, of course, men भी उसी तरह से important होते हैं, but the thing is, the women of our society very underconfident in that she doesn't understand. She thinks that she doesn't understand the gravity of the disease process, or she doesn't have a decision making thing. जब भी आप बात करें अपनी फीमेल जो आपके पास आती है, start explaining to her कि आपके साथ ये है, ये process है, this will be the treatment process. She always say कि डॉक्टर साहबा प्लीज मुझे 2 मिनट दे दे, मैं अपने हस्बैंड को बुला लूं, आप ये चीज मेरे हस्बैंड को समझा दें, या फिर आप ये चीज मेरे ब्रदर को समझा दें. So we need to work on the awareness कि that she can also understand that what is her disease process. She can also take the decision. ठीक है? So this is where we need to work, and I feel the awareness, because we are working in an era where social media, ये सारी चीजें इतनी common है. Make an awareness video and circulate it on the social media, right? Next. Next. So there are some preoperative considerations. Like number one is the diagnosis. Diagnosis is a challenge because of the atypical symptoms. And number two, education is very important. Awareness is very important regarding the disease process and the treatment process, because CABG is a big procedure. Of course, it's a major surgery, and it has got a very complicated course post-operatively, even if it is going smooth. Next. In the intraoperative setting, especially in women, I would like to highlight the multiple arterial grafts, because now we are getting younger women, and they are not actually so much active as the men are. And so there are, and because of some hormonal influences, we are not getting a good venous grafts. So it's better to go for the multiple arterial grafts in the small coronary vessels, apart from the technical challenges, because it is very technical to operate on a woman patient, especially because if you are talking about the tissue quality, we all know the surgeons in the participants, they know that it's really technical to operate on a woman. Number two, minimal invasive techniques, of course, mid-cap, robotics, these are again the options. If not in Pakistan, outside the Pakistan, because the cosmetic reason is always there, but not at the expense of the long-term patency of the grafts. Next, please. In the post-operative management, we all know that women has a little higher complication rate because of increased fat or fat mass or bleeding. Women gets more inflammation post-operatively as compared to men, and they have higher mortality because whichever score we take, any risk score, the woman has got a higher risk score because of these issues. Number two, tailored medical therapy. Of course, we have to again awareness that she has to continue the medical therapy. We have to give awareness to the family that they have now to support the woman, because earlier it was her who was supporting the whole family. Now it's the time of the family to support the woman. And rehabilitation, again, I would like to emphasize over the rehabilitation programs. It's important for both women and men, all the patients, but of course, women neglects her health. That's why we have to emphasize more that the cardiac rehabilitation program should be. Next. Again, the emerging advances, I already mentioned that robotics and hybrid cabbage is an option if you're talking about cost massive. And research needs, because we lack research between the outcomes of men and women in cabbage. Next. There are some papers that are pulled out, and this is a paper that shows the impact of women female sex hormones on the cardiovascular disease from mechanisms to hormone therapy. So it shows that before menopause, cardiovascular estrogen were also often used in combination with estrogens in hormonal therapy. Fluctuations in the sex hormone levels, particularly estrogen deficiency, were considered the specific risk factor in women cardiovascular disease. This is mostly because a majority of women are getting PCOS these days. So this has also an influence in the sex hormones, and then again the cardiac. Next. Another paper shows that atypical manifestation of women presenting with myocardial infarction at tertiary care. In an article, it shows that about 85% of the women were presented with atypical manifestations such as dizziness, sweating, shortness of breath, vomiting, palpitation, panting. So most of the patient women, they were presented with the atypical symptoms. Next. Again, another study which shows that 1/4 of the cabbage operation are performed on women, and women reported less improvement in the symptoms, lower activity levels, and poorer socioeconomic functioning following cabbage than men. Next. It's another paper that shows the operative outcomes of women undergoing cabbage from 2011 to 2020. It shows that women remain at significantly higher risk for adverse outcomes following coronary artery bypass grafting, and no significant improvement has been seen over the course of last decade. Further investigation into the determinants of operative outcomes in women is urgently needed. Next. There is another paper of the Journal of Cardiology. It shows the gender differences in the recovery, and it shows after cabbage surgery, women has a more difficult recovery compared with men, which is not explained by illness severity, pre-surgery health status, and other patient characteristics. Next. So the takeaways of my presentation are: number one, we have to be very very good at communication with the woman when she comes to the clinic. We have to tell her the whole process of the coronary artery disease, and we have to explain the whole procedure. And we have to emphasize that she needs to understand that she has to make her health as a priority, not neglect her health to the last stages where the healthcare provider is, handbound, and now we cannot do anything. Number two, we have to emphasize that the comorbidities, because we know that in the there's the last data of 2021 that it shows that hypertension is prevalent in 24.6% of the Pakistanis, and diabetes is prevalent in 27.8% of Pakistanis, and diabetes is more common in women. So we have to, emphasize and aware of our woman that she needs to understand and control the comorbidities in order to have a better outcome after surgery. Thank you very much.
Praveen, for your presentation. Let's move towards the questions. Anybody have any question from Iram Tarin? Dr. Asna? Dr. Don't have any
It's not a
question?
question, it's again a comment, and I think I talked about it initially.
Okay.
We need a societal change. It has to change completely that women also have coronary artery disease. And I think the best I can think of is the example that I used. I use the emotions. We need to tell the public at large that many more women die of coronary artery disease than they die of breast cancer, because the emotions come into play and they talk about it. And if it's an eye opener, not just for women, but for, I think, most healthcare professionals, they don't understand this simple point that women will die more is more likely to die of coronary artery disease or valvular heart disease than of breast cancer. Maybe we might be able to bring about a difference.
Very good.
I very much important. So Radha has left her presentation earlier in mid because of the internet disconnection. So I will like to invite her to complete her presentation. Dr. Radha?
Yes, ma'am. Yes, ma'am. Ma'am, can you share me number 17?
Number?
17.
17. 7.
Yes. So sorry for the disturbance. Can I start?
Yes.
Traditional ASCVD risk factors and emerging non-traditional ASCVD risks: diabetes, smoking, obesity and overweight, physical inactivity, high pressure, and high cholesterol level. In emerging non-traditional ASCVD risk factor for female, preterm delivery, hypertensive disorder of pregnancy, gestational diabetes, autoimmune disease, breast cancer and treatment, and depression also. So lack of physician knowledge. Fewer than 1 in 5 physicians, PCP, OBS-GYN, and cardiologists knew that more women than men die each year of CVD. From 1984 to 2020, level of recognition, 8% of PCP, 13% OBS-GYN, and 17% cardiologists. Physicians are more likely to classify women at a lower risk category for CVD than men, despite similar calculated risk. So surgery for coronary heart disease, coronary artery bypass grafting remains the most commonly performed cardiovascular surgical procedure, although absolute number have declined by more than 60% since the late 1990s among Medicare beneficiaries. In the late 1970s, women constituted only 13% to 16% of patients undergoing CABG, and the first major randomized trial of CABG included only men. In recent years, approximately 30% of Medicare beneficiaries receiving CABG have been women. Reasons for the smaller of women undergoing CABG include their lower prevalence of obstructive coronary artery disease and barrier in coronary artery disease diagnosis and referral for intervention. Next, please. Combination procedures that include valve reconstruction and CABG are also comparatively less frequent among women. Significant sex differences in the clinical profile of patients receiving CABG have been consistently observed. Women are typically 3 to 4 years older than men and more often present in urgent or emergency status. Hyperdiabetes, peripheral artery disease, and renal dysfunction are also more common in women. Women are more likely to present with anginal and heart failure symptoms than men, despite better left ventricular systolic function. So patients' reported outcomes after CABG, including health-related quality of life, have also shown sex-based differences. Men generally reported higher post-CABG physical functioning and emotional scores compared with women. The reasons for these differences remain unclear, but may incomplete revascularization and late presentation. Strategies to improve outcome in women who undergo CABG are needed and include adherence to sex-specific surgical treatment techniques during CABG, such as arterial grafting, use of complete revascularization, more studies to determine the benefit of off-pump techniques, and greater involvement of women in clinical trials to further investigate the differences between men and women with coronary artery disease. Next, please. In aortic surgery, the prevalence of aortic pathology is higher in men, who accounts for nearly 70% of patients with thoracic aortic aneurysm or dissection for both hereditary and degenerative pathogenesis. Despite the lower predisposition to develop aortopathy, women with thoracic aortic aneurysm are 3 times more likely to dissect or rupture, especially at smaller aneurysm size, and 40% more likely to die than men. Although women are often older and have more comorbidities than men, female sex has emerged as an independent risk factor for acute aortic syndrome despite indexing for body size. The underlying mechanism behind these observed sex differences in the development and natural history of time remain poorly understood. Aortic stiffness, a marker of aortic health, and atrial aging may contribute to the progression of TAD, with stiffer aortas being associated with a higher rate of aneurysm expansion in women. Worse pulsatile hemodynamics have been observed in aging women compared with men. Important sex-based differences are observed by the International Registry of Acute Aortic Dissection for patients undergoing emergency arc operation for acute type A aortic dissection. Women presented at an older age were diagnosed later and presented with higher rates of coma, hypotension, and tamponade. Next, please. Valvular heart surgery. Differences in outcome are also present in valvular heart disease. Current literature demonstrates that despite similar stenosis in men and women, aortic valve calcification is the most common mechanism of aortic stenosis. Women have a smaller aortic valve annulus corresponding to their smaller body surface area compared with men, with increasing rates of early coronary revascularization and decreasing prevalence of rheumatic fever in the pathogenesis of surgical disease in developed countries has shifted from rheumatic and ischemic in origin to one predominated by degenerative valvular heart disease. women maintain in a significantly higher rates of rheumatic involvement than. So in a randomized controlled trial of 251 patients, 38% with severe ischemic MR undergoing mitral valve replacement versus mitral repair, women had higher mortality, 17.4%. In a retrospective cohort study of over 8,000 patients at Mayo Clinic, women with severe MR were less likely to undergo mitral valve surgery despite large LV and LA size, even when indexed to body surface area. So women are more likely than men to have mitral valve stenosis. Regurgitation predominantly affects women. Isolated TR surgery is associated with high operative morbidity and mortality for both men and women. So in conclusion, much progress has been made in cardiac surgery. However, much needs to be done. Review of current literature shows that women still present later in the disease state get less aggressive care and more likely to have residual disease, all lower quality of life after surgery. Moreover, there is continued sex-biased research with wide knowledge gaps in both basic and clinical studies. Thus, development of sex-based algorithms for timely diagnosis risks stratification, monitoring, and referral for intervention in women, incorporating sex into research, investigating mechanism of sex difference can help narrow the sex gap. Thank you for your valuable time. For this, I would like to conclude my topic.
Thank you.
In high altitude regions like Nepal, where you are living, after any gender specific adaptation you have made to cardiac surgical care to address the hypoxic challenges in
Yes,
women?
ma'am. Yes, ma'am. In high altitude, females are more prone than males.
Hypoxic challenges
Yes.
in high altitude areas of the Nepal.
Females
Like that
are
we
more.
have, like that we have in our northern areas of Pakistan. We are also facing those challenges. But in your country, what is the status? Gender-based challenges.
Yes, ma'am. I think in our country, females are more prone in Himalayan region. They are prone to pulmonary edema and pulmonary embolism also.
Dr. Hasnan, you want to say something?
Yes, so it just occurred to me, I think when we look at the mechanisms for poor outcomes after coronary revascularization in women, one of the things we've not talked about is the presence of small vessel disease. This is disease beyond your graft touchdown point. And I think women are notorious for that. And obviously you can't do anything to that. And that may in part explain the poorer outcomes in women from this operation. So this operation may not be the panacea for all cures in women.
Thank you, Dr. Hasnan. Lastly, we have Dr. Nena, consultant cardiothoracic surgeon at AKUH Hospital, Karachi. She will be speaking on women after cardiac surgery, a gender-specific approach.
Ji, Assalamualaikum. Thank you so much, Dr. Khalida, for having me here today. Can I have my presentation, please?
Yes.
So today, my name is Dr. Hina Inam. I'm a consultant cardiothoracic surgeon from Aachen University Hospital. I'll be talking about the post-operative recovery in women after cardiac surgery, a gender-specific approach. Next. nothing to disclose. So there's this perception that women represent a low-risk population for cardiovascular diseases. This is something that needs to be reconsidered. This is because women are most likely to be susceptible to unhealthy behaviors. The risk factors which have different impact on both the cardiovascular morbidity as well as mortality of women as compared to men. If we talk about clinical trials, well, most of these clinical trials have women who are underrepresented, hence leading to limited knowledge. When we talk about risk factors, well, our risk factors, when we talk about risk factors in men, hypertension, diabetes, and that's about it. While in women, these are divided into different types. Traditional risk factors, which are the same as men, like hypertension, familial hypercholesterolemia, metabolic syndrome, smoking, diabetes, while the non-traditional risk factors, which are very important to be considered in women, are diseases like autoimmune diseases, microvascular dysfunctions, hypercoagulable states, and contraceptive drugs. Something that is not talked about in women are the different diseases that concern women only, like pregnancy and peripartum cardiomyopathy, which has a serious impact, menopause, and its substantial cardiovascular risk factors that has that effect on the women. The sex differences in COVID-19 cardiovascular implications, and then cardiovascular diseases in advanced age in women as compared to men. Next. So this is something that Dr. Hasnath pointed out as well, that breast cancer is the second leading cause of cancer death among women, 1 in 8 women being diagnosed in her lifetime. And all of us know what when the pink ribbon day is. However, next. 1 in 3 women have some form of heart diseases. And that notion that women are saved by the HDLs because their sex is also false, because 10 years after menopause spikes up. Next. In a recent paper written in the European Journal of Cardiovascular and Thoracic Surgery, it was said that in European women, 51% deaths were due to cardiovascular disease. However, it was just 3% in breast cancer. Here, I'm not at all undermining breast cancer, but it's something that's really important to see here is the 51% of deaths that are happening because of cardiovascular diseases. Next.
Very.
This is a recent paper from Lancet which suggested that 275 million women were diagnosed with cardiovascular disease in 2019. 8.9 million of these women died from cardiovascular diseases. So they suggested, or this is something that is very important to be known, that cardiovascular disease among women is not only just understudied, it is underrecognized, it is underdiagnosed, it is undertreated, and women are underrepresented in clinical trials. Next. So if we talk about the risk of smoking, well, that too is very high in women as compared to men, because women metabolize nicotine faster, especially those who are taking oral contraceptives. Next. Already we know that type 2 diabetes mellitus doubles the cardiovascular risk in men. However, it triples the risk in women, and women are more likely to be severely disabled after a stroke as compared to a man. Next. If we talk about the symptoms, well, the most common symptoms that people will present with is chest pain. However, in women, the symptoms may vary. They can be as simple as nausea and vomiting, shortness of breath, jaw pain, fatigue, palpitation, syncope, cardiac arrest, making it difficult for them to be diagnosed and hence present lately to hospitals and hence be diagnosed late as well, leading to bad outcomes. So we talk about the importance of gender-specific approach. Next. Women have small coronary vessels. They have a unique hormonal profile and hence have different responses to surgical intervention, which all of this leads to higher complication rates, a longer recovery period, and high mortality in women. Next. We know that there are a lot of different physiological and hormonal changes take place during pregnancy. This causes both the mother and the baby to be at high risk. Hence, special consideration should be given to both the baby as well as the mother in all of these stages, whether it is preoperative, intraoperative, or postoperative. Next. So what are the key factors which influence the recovery in women? Next. As told earlier and by a lot of different presenters here, we have small coronaries and smaller heart sizes, which can complicate procedures. There's estrogen, which has effect on the vascular health, inflammatory responses, and healing rates. If we talk about comorbidities, well, women are often older at times of surgery and can represent with different risk factors like diabetes, hypertension, osteoporosis, thus complicating recovery. Women return to their caregiving responsibilities faster, which may hinder adequate rest and rehabilitation for them. Another very important thing that is not considered at all, especially in our part of the population, is the prevalence of depression and anxiety in women, which affects and can which can affect the adherence to recovery protocols. They have limited access to resources, support systems, and follow-up care. Hence, this also impacts their recovery. At all the women in lower middle income countries specifically, they may face delayed care because of societal roles, financial dependency, and lack of prioritization of their health. So what are the post-operative challenges for women? There are more at risk of having post-operative atrial fibrillation because of increased inflammation and hormonal factors. There's increased risk of infection because of reduced access to post-operative care in some of the regions. Because of smaller body habitus, increased sensitivity to surgical trauma, they may have persistent pain, which can also affect their post-op recovery. Because of their lack of support, they can be lower referral rates, lesser physical activity. Because of family obligation, their rehabilitation can be delayed. As told earlier, psychological support is something that is not provided at all to women here. That is something that can be made a part of the post-operative recovery of women. And higher mortality that is known already. So if we talk about the evidence-based strategies for gender-specific recovery, next. We can tailor women's unique needs and make our preoperative, intraoperative, and postoperative care as such so that it is tailored to these women, optimize the management according to the patient's specific needs. And we can focus on a structured rehab program specifically which have been designed for women. We can adhere to barriers like childcare and transportation, etc. Next. Mental health, I will keep on stressing that, is something that we do not talk about. We can integrate counseling and psychiatric care in the regular post-op care that we give to our patients. We can screen them for early depression. Nutritional guidance is something that is very important, specifically people coming from lower middle income countries. We can have the family involved in their care, the community involved in their care, which can help with better post-operative care of these patients, implement outreach programs, and educate family members. If we talk about research and recent evidences, next. So the recent studies have highlighted that there's a global gender gap. Gender-specific cardiac rehab programs which have benefited in improving the post-operative care of the patients, and there is role of psychological counseling. So in conclusion, a gender-specific approach to post-operative recovery in women entails acknowledging and addressing their unique biological considerations, their psychological issues, their social challenges, and all of this can significantly enhance outcomes for women recovery from cardiac surgery. Thank you.
Thank you, Dr. Anam. Nena. Thank you, Dr. Nena, for your comprehensive talk. And if any question from the audience or chairpersons, Dr. Rifat Tanvi, you want to say something? Oh, so I have one question from you. What adjustment do you recommend in anticoagulation therapy for the woman experiencing heavy bleeding after valve replacement surgery?
Yeah.
Just even before that, we discuss whenever we're preoperatively managing these patients. We sit with the family, we sit with the patient, tell them all about the different valves that we have, tissue valve as well as mechanical valves. We tell them what are the pros and cons of both, and then let them decide of what they want to do, whether they would want a mechanical valve or would they want a tissue valve. And once they've decided, it's important that they know what are the pros and cons of both. If there's somebody who's come in with post-operative bleeding, then that depends what the cause of that bleeding is, whether it's immediate post-op or whether it's because of the warfarin that they're taken. We have hematology on board. We ourselves admit the patient and then get gynecologists that are well versed with our patients on board. And then in the form of a multidisciplinary care, we provide that to cater whatever the problems the patient's suffering from.
So, can I add to that? I think in your pre-operative evaluation, you need to figure out which woman may perhaps be at higher risk of bleeding post-op.
Yes.
And it's
Yes.
okay to talk to the families and give them the choice. But I think 9 out of 10 women will turn around and say, or the families will say, what would you recommend? So we have to end up giving a recommendation. And if there are red flags about bleeding post-op, I would definitely either say, if she's completed her family, consider being and having a hysterectomy first or later on. Or the other thing would be to, if she wants to have a family, to go down the prosthetic valve route.
Thank you, sir.
And and the problem is that valvular heart surgery usually can be done during the productive years of the life due to menstrual period, everything. So this is for a question for the public as well. If you will answer it.
I think it's a very important question that you've asked. Yes, we come across women who are from all walks of life, young as well as old. So I'll give you an example from somebody that we just recently operated. This was a 28-year-old who had presented to us with mitral stenosis, and she initially had come with ischemic heart, ischemic limbs, and later on we found out that probably that was because of the mitral stenosis, and she was throwing out these emboluses all over her body. So we had a really detailed talk with the family where we talked about both the valvular, both the tissue valve as well as the mechanical valves, told them that, she will be in her reproductive years where she will be getting pregnant. And at that time, they might have difficulty choosing a valve, maintaining INR. So everything was talked about, and yet the family, not just one thing, such patients. Yes, a female might be coming from an age group which is in the reproductive years, or she has to go through periods and she has to go through pregnancy. But we have to also consider that does she come from an area where she herself can manage this INR? Is she educated enough? Does she have a support system that can identify when the valve's stuck or she's not gotten the INR? The correct amount of warfarin, will she be able to maintain that INR? So it's not just that simple. Many times a person may be really well educated, but they may not still be able to maintain that INR. We've had multiple women come in with that. So it's I think preoperatively, then has not said, not just telling about everything, but also giving them to how you've perceived the patient, and knowing your patient really well helps a lot, because would to maintain that INR or warfarin dosage. But if they're coming from an area where they won't even get that warfarin, or they won't be able to monitor that INR or get in contact with the surgeon in case the valves get stuck, so that's on you. You can always make a educated, well-informed decision whenever they ask you what would they want. So I think Dr. Hasnat's point is very valid here as well.
Ma'am.
Okay.
If I would like to add on some. Ma'am, it is very important know whether a woman with a mechanical valve in situ and on warfarin is really having heavy periods secondary to that INR derangement or secondary to that warfarin treatment. The woman may be suffering from other hormonal problems or any other, for example, she may have a fibroid and something like that. So I think gynecologist review of such a patient for diagnosing whether the cause of that heavy cycle is secondary to INR derangement or warfarin, or it is secondary to some other cause. It is very important. So, if the female may not need a stop of warfarin or change of a warfarin, it may be that she is in need of some hormonal supplement. So, I think it will be better to check for the hormonal derangement in such patients, and if they are deranged, they should be tackled, and they should be continuing on warfarin treatment, or they may be for the time being converted to Calaxine or other, so that we can reduce the flow as well as to optimize the hormones that can give benefit to the patient. I think so.
Thank you for your very important comment on this issue, which we face during our consultation. These patients, we have to guide them regarding after follow-up period of surgery.
Yeah.
So now have the conclusion webinar. I would like to invite Dr. Has and other chairperson to share their insight and concluding remarks now. Rupert,
Now, ma'am,
you want to say something?
I just want to say for the is there's no doubt, especially in female, and these are neglected, and the risk factors and the contributing factors all our presenters had mentioned, and with the counseling as well as the awareness to the public, as well as also the medical people, we can handle this issue. And while we decide to manage the patient, the decision should be individualized for every patient, irrespective is a female or male. They are individual and with different age groups. So, and every patient should be managed and processed. The management should be processed with the multidisciplinary team approach. So, we are not only managing or treating the echo or the angiography or the scat reports, but a patient as a whole. And the post-operative management, the recovery is very important, as one of our presenters also mentioned this. And especially in the female patient, the female who are obese, elderly, the osteoporosis is very common, and that causes very difficulty in post-operative management of the patient. Patient ICU and the hospital stay increased because of these factors. So when we are managing a patient, if it's a female of any age group, is a male, we should always is my suggestion, we should do the multidisciplinary approach with the opinion of the cardiologist, cardiac surgeon, as well as the anesthetist and the pulmonologist, because these all are with this we can manage every patient in a better way, and the outcome inshallah will be better. And public is, because if we decrease the incidence and the prevalence of these disease in our society, for this the risk factors that are common in male and female, that is the stress, alcohol consumption, smoking, as well as the diet. With these factors, we can decrease the this is issue that is very common in our society as well as in the world, and that is also causing the the financial burden to our society. Thank you, ma'am.
The comorbid conditions, you see, diabetes is more common in the women, you see. And for a woman,
Ma'am, it's very common.
diabetic woman, yes. So for a diabetic woman undergoing cabbage, what evidence-based strategies do you employ to prevent post-operative wound infection, doctor? This is question for the
Before
Nena. Post-operative strategies to control the infection
In women.
Yes.
Yes, so it all depends upon the patient, seeing the patient, taking a comprehensive history, knowing if the patient's diabetic, making sure that the sugar is well controlled, having endocrinologists on board earlier from the get-go. If the patient has any other comorbids, making sure that they're well under control. Inoperatively, making sure that the patient has been properly prepped and draped. The sternum is cut from the midline. The IMA, while taking the IMA, you've not buzz the whole of the IMA bed, and then you've made sure that the vascularity is maintained there. While you're closing the sternum, you've made sure that the sternum is there's no non-union there, and the both the plates are well together, making sure that the wounds close correctly. Post-operatively, making sure that the patient's hemoglobin is well maintained, the sugars are well controlled, the wound is checked at regularly. And similarly, when the patient comes to your clinic, making sure that you check for the sternal stability, making sure that the patient's sugars are okay. So it's not just one step that you take in maintaining and making sure that the patient doesn't have an infection. It's from the get-go, from the point that you see the patient to the point that the patient goes home and then keeps on coming to your clinic for follow-ups. It's a holistic care that you provide, which prevents infections.
So can I just highlight what Nena just said?
Yes.
I think let me point out the important stuff in it.
Yes,
The important
Dr.
stuff is to have a well-controlled diabetic who goes into surgery. Sometimes that is not possible. If it is not possible, then intraoperatively ensure that you have prophylactic antibiotics on board, do all the other stuff that Hinam talked about, and also maintenance of good glycemic control. Now, by that, what I mean is you cannot overdo it and should not underdo it. Try to maintain sugars in the 150 to 200 range. They shouldn't be too high. And also at the risk of having low sugars, you should be watching out for that. So the other issue that just came to my mind is that Hina knows about it. There's a couple of drugs that we do stop now before surgery, like EMPA and DAPA and the ACE inhibitors, because they cause vasoplegic shock after surgery. So removal of those agents perhaps could impact upon the outcomes and produce better outcomes. So you cannot be too focused on just looking at the diabetic control. You need to look at what you're doing and the effect it's going to have on the body. To sum it up, I think if you look at coronary artery disease, it's awareness, early recognition, early treatment is what is going to make a change. Intraoperatively, like I said, we know we can't do anything about this small vessel disease. That is an issue. And then quite clearly, operative and perioperative care needs to be better. And I think that will have some degree of impact. I'm going to talk about valvular heart disease. I trained abroad for about 15 years. And during my 15 years, I only saw 2 rheumatic heart patients, which we operated upon. So the society and the government has a role to play. Better economy, better socioeconomic status, nutrition translates into almost elimination of rheumatic heart disease. Unfortunately, we're talking about eliminating rheumatic heart disease in a country where we've not been able to eradicate polio, which the rest of the world has done. So I think there are these, but we should continue to work on what we know is detrimental to the nation's health. and which is neglecting their nutritional status. I think these things will have an impact in the long run on cardiovascular disease. The other thing is we continue to talk about diabetes. The impact of diabetes currently in the Southeast population is more than the impact of COVID. We're living in an era of a pandemic, and I think it's only once you start putting out stuff like this to the lay public that the chances of you dying are more from a coronary artery disease than it would be from COVID. That kind of gives it the context and the background to people that, oh, this is really that important. So I think we have a duty to our population to educate them.
Yes.
Thank you.
There is importance of awareness, creating awareness in population. So thank you so much. On behalf of GoRed for Women, Pakistan, and Scientific Council of Women with Heart Diseases, I extend my heartfelt thanks to all our speakers for their remarkable presentations. So I can see Dr. Shehbaz or Emma Shehbaz also on the screen. Dr. Emma Shehbaz, have you any?
Yes, madam, it was a very nice initiative, and I'm very much impressed with your leadership. And at Punjab Institute of Cardiology, facing same. Are you listening me? You can listen to me?
Yes, we are listening to you.
Okay. So we don't have any discrimination now because the number of patients in both the categories are increasing. So there is hardly a little bit difference, male and female ratio, because the burden of disease is immense in our institution. So we have to deal with both categories with the same zeal and same enthusiasm. Yes, there is a little bit difference in female gender because some of them are diabetic and obese and less physical activity in Punjab. So we also encourage them to do lifestyle modifications. And as far as this webinar is concerned, I think it's a very good initiative by GoRed for Women and Punjab Institute of Cardiology from the platform of Pakistan Cardiothoracic Society in collaboration with your organization. We would like to host an next of your webinar, and the topic should be open heart surgery in pregnancy. So that is a very good topic, and we should discuss about it because there is a lot of gray areas in understanding and communication gap between the gynecologist, cardiologist, and cardiac surgeon. SOPs and format. Yes, we should have an next webinar on open heart surgery in pregnancy and during pregnancy or in pregnant women, especially rheumatic heart disease, mitral valve replacement, MR, MS, diagnosed during pregnancy, how to keep with it and how to handle it.
Yes.
So we will request all of the members of this forum to engage with us, and we will intimate you regarding the time and arrangement of this webinar in collaboration with Dr. Khalida Soomro and her team.
Thank you so much, Dr. Amma Shabbat. You made my work easy. You see, I was looking for some institute who can take these responsibilities in organizing workshops in their institutes and for the awareness of postgraduates and the other doctors in institute. These webinars recordings are on the websites, YouTube, but it will be much better if we organize these webinars from the various speakers of the country in our medical institutions for the postgraduate students and the medical staff. Thank you. Looking forward for your cooperation in this regard.
Yes, I'll send you the invitation for the next webinar, and it will be with your
Okay.
collaboration. And I have requested in the last to play the video of that Nena, so that everybody should have some insight about her. I have sent it into the group. If you can play it, that will be a good contribution.
Yeah.
I said, name me one woman. Who is your model? She couldn't think of any. I said, I want to be a surgeon. Not I'm going to be the first to do it and I'll become famous. That wasn't it at all. No, I want to be a general surgeon. That was the first time I saw in her this tremendous drive. I'm going to do it. Charles Hofnagel developed a valve that was placed in the aorta. She got excited about the cardiac surgery because she assisted him. And she also did research on valves at Georgetown. In the meantime, Andrew Morrow becomes quite interested in her plans. Morrow was a wonderful mentor. He recognized her skills and her dedication and her positive interaction with patients. It became apparent in the field it was going to be necessary to have an artificial valve. And she began to stitch something together at home. She did dog experiments in the laboratory, and then came the first mitral valve replacement. She had half a dozen firsts.
We're especially proud because my mother is the first boarded surgeon. You can see her here, surrounded by men. To a large degree, she didn't care so much about what people thought about her. She was willing to be her true self.
And she wasn't doing this to get any fame and recognition or to be in any newspapers, or she just was doing it because of her love of being a surgeon.
This picture really epitomizes the joy of her as a scientist. She just...
And the focus.
The focus and the determination. She...
I remember playing around with gluing valves and little metal structures that she was always trying to make things work and work better.
It was her approach. There was a problem, you had to solve it, and it will work.
Good surgeons work in a hurry. Time means a great deal. And time meant a great deal to Nena.
We didn't know that she went back to work at night after we went to bed, or that she got up early in the morning to do things. We just knew what she was like when she was with us. And when she was with us, she was fully present. The work made my mother very happy. And without it, she wasn't as fulfilled. To be a happy person is more important to be a really well-rounded parent. And so if you can find that balance and that you are made whole by the work that you're doing, that is really important, and you can still communicate to your children that you love them.
She was really remarkable. She was complicated in that she had sort of a shell as a shy person to the outside world, but had so much love inside of her.
Our mother could not cook. Our mother could burn Lipton's noodle soup and make and make minute rice taste terrible. We grew up in a non-traditional family. Because of that, we realized that a woman can have a family and a career, but We also saw the struggles that came with it, the balancing of different needs and whose needs take priority and how do they work that out. We observed their challenge in doing that.
There is a shortage of women in this particular specialty. That needs to be corrected. This initiative, we hope, is going to make that easier.
It's really going to create a path for women in the future that she would have been astonished by.
I wouldn't consider her to be a feminist. She just felt that it was necessary to go out into this male world and to show that you could do it. And doing it at that time meant doing it better. Being as good as is not good enough. You've got to be better.
Mother had an incredible affecting women in medicine decades after her passing. That means everything to us. I think she'd be very proud because she did care very much about mentoring people along the way.
Oh, I think she'd be thrilled. She would be thrilled.
Women. Nena Braunwald was the first woman cardiac surgeon actually in the world, and the first to get board certification by the American Board of Thoracic Surgery here in the United States. But besides these firsts as a woman, she was also an incredible technical surgeon and scientist.
She was the first woman to actually implant a mitral valve that she helped to develop in the lab, which is pretty crazy if you think about it. You actually build a valve and then put it in people, and they live in the 60s.
She was engaged in it all research, so she contributed not only to cardiothoracic surgical endeavors and research endeavors, but also these were translated into other subspecialties of surgery, including transplant. She mentored students. She was on the admissions committee at Harvard. She operated, so she was clinically involved as well. She had a family, children, 3 daughters, a husband. Yeah, she was managing to do it all.
At the time that she was terminally ill, our oldest daughter said to me, "You know, Dad, we should really be doing something to preserve a memory of Mom." And that had a great impact on me. And I thought that the thing that Nena would have wanted more than anything else in her professional life would be that the kinds of opportunities that she sort of fell into and then succeeded, that should be made available to other young women.
A human life and the ability for a human being to be healthy while they live out their life is really the most crucial thing that happens. And to be a part of trying to make that possible, to me, seemed the most important thing that one could do.
Ever since I was a child, I wanted to be a doctor. Once I was in medical school, I fell in love with surgery, and then I had the opportunity to watch a heart transplant one night after my first year of medical school, and I was hooked on heart surgery. I was introduced to the potential scholarship, and so we wrote a grant and applied for that, and actually I was awarded the grant. During those 2 years in the lab, I had the opportunity to travel. I got to meet Dr. Braunwald at the American College of Cardiology, and I had a chance to thoracic surgeons and the Society of Thoracic Surgeons, which are the 2 big national meetings.
I got 2 of her grants. So the first grant was when I was a surgical resident, and that helped me get into the cardiac surgical program that I really wanted to get into, which was the Brigham program. And when I was a young attending, I wanted to continue my research endeavors, and I was interested in clinical research at that time. I therefore applied for the Nena Braunwald Research Award, so it helps young surgeons in their career. move along, like get a K-23 to complete my project.
And from being a Brownwald recipient is where I am. The opportunity that was given to me way back when I was a second-year general surgery resident set the wheels in motion and just reaffirmed to me over and over again that every opportunity I had led to another opportunity. So I think that your life goes down a pathway, and I think that this was what started the career trajectory for me.
Women are incredibly important to the future of medicine and surgery. Women are 50% of our population. And yet in cardiothoracic surgery, only 6% of our specialty. What we're missing is talent. And what we want are the most talented people in our specialty because they're the people that make academic advancement and take great care of patients.
The field of cardiothoracic surgery is open to men and to women, and that there's no barrier that shouldn't be broken at this point.
I owe a lot to my mentors that I've reached where I am now. And now that I have reached a certain level in the academic world, I think it's my responsibility to make sure that these opportunities that I was given are available to the younger generation. So I think it is imperative that I mentor medical students, surgical residents, and cardiac surgical residents to the best of my ability.
I think that there are so many restrictions in the medical environment now. There's not a lot of money that's being donated for grants and things. So I think that this foundation is leading the effort for innovation, especially for women. There's so many cutting-edge technologies that are out there now, smaller ventricular assist devices, ICDs that don't even have to be implanted, lots of new technology for valves being put in without surgery in different positions. And I think the only way that we're going to pursue that is if we stimulate the interest in people that are coming along and fund that research through the foundation.
The Thoracic Surgery Foundation has made a commitment that we really want to develop the Nena Star Braunwald Research Awards to a sustainable level that will outlive us all, that will continue to support research funding for early career women in cardiac surgery and residents and fellows in cardiothoracic surgery that is sustainable.
I think she showed us that if you're something, just pursue it. Do not let obstacles get in your way. Do what you want to do and do it as well as you can, and you will succeed.
Because of what Nena Star Braunwald did, many women have benefited from this. I think she'd be very proud of what's happening. It's our responsibility to let more people know about it.
I think it's a worthwhile cause to donate to the Thoracic Surgery Foundation, specifically for the Braunwald Scholarship, because I think there are many, many women that we're mentoring now that are interested, and I think it's our duty to give them the same opportunity that we had when we were coming along.
Thank you so much. If anybody comments, please.
Can I go?
Yes.
So Ahmed Shabazz, thank you very much for sharing that video. I just need to give you a backdrop. We've been talking about society and societal changes. Nena Braunwald was born about a century ago. Most of her work was done about 50 years ago. If you go back to the Western world at that time, and UK and US specifically, there were biases. The biases were, and I'm going to be very clear about it. There are places in the US where it used to be written, dogs, colored people, and women are not allowed. So she grew up in that era where slavery was going on. Blacks and coloreds were discriminated against. Women were relegated to the second position, and yet she rose out of. So quite clearly, there's a message out there for each one of us that is, you continue to work, society can change. Do not give up just because it's not working. It'll work. It's more important to try and lose than to have not even tried at all. So it's courageous of people like Hina and Am and the other people over here, the cardiac surgeon, Dr. Rifat Tanveer, our friend from Nepal. I think you are bringing about that change. It takes a huge toll on your life, on your personal life. There's no two ways about it, but we've seen with a supportive family, Nena Braunwald's husband, we all know from the Braunwald book of cardiac medicine, he was such a renowned figure, and I think he would not have made it to the point that he has without that active support from his wife.
Great.
Sonia?
Thank you very much, everyone. It was really a great opportunity to be here with all of you and to share on this important topic of valvular heart cardiac surgery in women. And really, it was very, very boosting to know about Dr. Nena. And I hope we all wish to have better and better opportunities in our coming careers so that we can go for a better culture as well as better management of our patients in our setups, inshallah. Thank you very much.
Dr. Radha, you want to say something?
It's really great.
Thank you so much. Thank you so much, ma'am, for giving this platform.
Okay. So let us continue to work together, advancing cardiac care for the women. It is related with the medical care, medical cardiac care or cardiac surgical care. So we have responsibility to work in this regard. Thank you so much. Stay safe.